Thank you, sir. Uh, Firstly, I would like to, Dr. Satyavan Sharma was one of my teachers, and on this Teacher's Day, I would like to acknowledge his contribution in no small way to wherever I have reached today. So let us go to syncope. It's important to recognize that syncope is not a diagnosis. And the definition of syncope, let us reiterate, because if we are clear in our mind about the definition, then we will be able to stratify or classify our patients who come with similar symptoms into whether they are syncope or unconsciousness or epilepsy, etc. It's a sudden loss of postural tone followed by loss of consciousness. It's very important. The postural tone goes first, and therefore most patients with syncope slump to the ground. They don't crash to the ground. And unless they are close by to a sharp table or something, generally, they don't hurt themselves. There are variable warning symptoms. There may or may not be, but some patients do have warning symptoms, especially those who have neurocardiogenic syncope. They sometimes can recognize that if you're going to feel uneasy, sweaty, or some unexplainable sensation, but they know we are going to faint. Most important, there is a spontaneous and complete recovery. Now, if we look at these three pillars for the diagnosis of a symptom as syncope, then you realize that it is basically a global and sudden reduction of cerebral blood flow. That's the only underlying pathophysiology that can lead to syncope, where you faint but you recover completely. And that's because there is a prompt restoration of the global cerebral blood flow. As you fall down horizontally, you return to some sort of blood flow which allows you to wake up. So therefore, syncope is not a brain disease. Syncope is not because of a transient ischemic attack. Transient ischemic attacks in the vertebrobasilar territory can give unconsciousness or sometimes syncope, but they are associated with other symptoms classical of vertebrobasilar ischemia, whether it be diplopia, dysarthria, etc., etc. Isolated syncope is not a TIA. And what follows, therefore, is that imaging of the brain by whatever modality and electroencephalogram do not help, they rather confuse you in the diagnosis of syncope, and therefore should not be done as a primary investigation for syncope. For example, you do a CT scan of the brain or an MRI and land up with some calcification of the basal ganglia or mild dilatation of the ventricles, which are dustbin diagnoses for the underlying cause of syncope. And of course, EEG looks like ventricular fibrillation. So the same EEG to two different people, you can come with two different diagnoses. So the first hurdle in syncope, is it a faint or is it a fit? If it's a fit, of course, by all means, you have to pursue neurologically. But if it's a faint, think of everything else rather than the brain. If you're not sure whether it's a fit or a faint, then look for the common causes first. And if we look at the causes of syncope, the commonest large substrate is what we call neurocardiogenic syncope, which is a broad umbrella term. It includes the most common, that is a vagal or a vasovagal syncope. In elderly people, carotid sinus hypersensitivity. Reflex syncope, that is micturition, again a common scenario in elderly people. Post or perimicturation, cough syncope. Then of course you have postural hypotension in patients taking antihypertensive drugs, diuretics, elderly people. Then you come to the cardiac arrhythmias, structural causes and other causes which account for less number of cases. Finally, one must remember that almost 1/3 of patients of syncope still remain undiagnosed, and we say it's an unknown cause of syncope. In practice, what I have found the commonest syncopal situation, one of the common ones is in elderly people. When they get up at night or to go to the toilet, or early morning they get up and before breakfast they are going to the toilet, they have a syncopal episode. So this is one common scenario. The other common scenario is in young people who get classical vagally mediated syncope. They get nausea, epigastric pain, sweating and syncope. If we look at the evaluation of syncope, the first step and the most important step is a detailed history taking from the person who has from the patient and a witness if available. Because out of all the investigations, if you take history taking, clinical examination and investigations, the diagnosis is most often reached on history taking. And based on the history, you can diagnose vagal syncope, situational or reflex syncope. History and simple clinical examination, you can diagnose postural hypotension. If the patient is taking any drugs, and if the ECG does show you, if you are fortunate enough, and the ECG shows you an arrhythmia or a substrate for arrhythmia, you can diagnose the cause of syncope. So when this basic examination, clinical examination is not diagnostic but is suggestive of certain disease, then you follow it up with the appropriate investigations. A word about carotid massage. In elderly people, don't do it in the clinic, and be very careful that you've ruled out a carotid bruit before you do a carotid massage. If you have no clue from the basic investigation, then that means you don't know whether to pursue the CNS cause or cardiac disease. Then look if there is heart disease, either clinically, ECG and echocardiogram. If the heart disease, structural heart disease is present, if it's present, then you follow it up either with a Holter or an EP study. But if there is no heart disease, then there are various investigations listed depending on the frequency of syncope. If the syncope is once in a many days, then doing a 24-hour Holter is unlikely to be of much yield. But if the syncope is very frequent, then a 24 or a 48-hour Holter may be useful. A tilt test is useful in selected patients. However, its usefulness has gone down over the years because it has 30% false negative and 30% false positive. So any test which is so much false negative and false positive is not very useful, and it generally is, if you have a good history taking, it doesn't add much to your diagnostic ability. Why is it crucial that we must try and prognosticate to a patient with syncope? Because we need to know whether this patient with syncope, is he at a high risk for sudden death? That is the most important question that we need to answer. A small proportion of patients of syncope are at risk for sudden death, but it's important to identify that small proportion of patients. So the second hurdle, what do we do? How do we prognosticate in those 1/3 of patients where the cause is unknown? That again depends in the unknown causes whether there is heart disease or not. If the ECG is normal and the structure, functional LV function is normal, then the prognosis is benign. So you have unexplained cause, but a normal left ventricular size and function, it's a benign prognosis. If there is an abnormal left ventricle, then it's a grave prognosis. So that's how we tackle the 1/3 of patients in whom we cannot identify the cause of syncope. What are the high-risk markers amongst patients with syncope? So as I said, ventricular dysfunction, the most high-risk marker. QT prolongation on the ECG, a very high-risk marker. Exertional syncope, if someone has syncope on exertion, it's very likely either it's a cardiac arrhythmia, dangerous cardiac ventricular arrhythmia, or there is a severe pulmonary hypertension, or there's an outflow obstruction. And most important, always ask for a family history of sudden death. It becomes a high-risk marker. In those whose syncope is very, very infrequent, you need to pick up the ECG during syncope. You need a test which can immediately record the ECG over a period of months. For them, you must be aware of something called as implantable loop recorder, which you put subcutaneously and which has a reasonable diagnostic yield in these patients whose syncope is few and far between and where you cannot identify a cause. You suspect or you want to rule out a transitory bradycardia, what we call paroxysmal AV block, or a transient tachycardia. Let's look at this one example. An elderly gentleman with the old bypass came with a transient uneasy feeling, severe LV dysfunction, but fairly stable. The ECG showed left bundle branch block and a lightly prolonged PR interval. So the question was, is the dizzy feeling bradycardia? Is the dizzy feeling tachycardia? Or is it unrelated to the heart? Because there is structural heart disease, because you have unexplained syncope or near syncope, according to the flow chart, you should proceed with Holter. Holter was normal. The next step should be EP study. So it could be AV block, it could be ventricular arrhythmia, it could be anything else. The EP study showed normal conduction. So the atrium is paced at 125, the conduction, all the impulses conduct to the ventricle. So though there is left bundle branch block and a little prolonged PR interval, yet all impulses do conduct. So it does not seem to be AV block as a cause of syncope. But the moment you pace the ventricles here, you induce ventricular tachycardia, what we call monomorphic VT, and the blood pressure crashed, and the ventricular tachycardia luckily could be terminated by overdrive pacing. So you had the cause of syncope, which is scar VT, an old MI scar, in which re-entry circuits can form and give rise to VT. So now if we summarize the diagnostic methods and their yield, we see that the history and physical examination give the maximum yield. And amongst all the tests, if at all there is any test with a reasonable yield, it is the implantable loop recorder in patients who have very few episodes of syncope and far between. Thank you. The cost is around 40,000 rupees. If these patients need a pacemaker later, they minus this cost from the cost of the pacemaker.
Any other question? Yash, there are many patients who have a mild hyponatremia, elderly people particularly on drugs. We often find they get this syncope, those who are prone to develop it. Is it important to look at hyponatremia in clinical practice?
Yeah, I think hyponatremia, can be a marker that these patients are over diuresed and they may be having postural hypotension, because it can give drowsiness, hyponatremia by itself, but by itself may not give syncope. But I think many of them may be having postural hypotension, right,
Yes,
which you may not necessarily pick up that time in the clinic.
Yes, there was a symposia in the European, in ESC, which I attended on syncope, and they found that in the elderly population, one of the most common variable was presence of anemia, especially in the elderly. They said this is a very important thing, so trivial that we neglect. And second thing, they showed a lot of cases of syncope which were recorded, simulated, and they found that many times patient may even have something like a transient fit, but these are not seizures, and they are a part of syncope, and we should not sometimes see even a slight, a shaking of the hand or something, take it that no, this is neurological.
Absolutely. Prolonged hypoxia can give a convulsion because of bradycardia. And I had another case scenario, anemia in elderly, especially those on aspirin and clopidogrel, and little blood loss taking place. The hemoglobin may not go down if it's a sudden blood loss, but the hematocrit may not go down, but you should suspect blood loss as a cause of syncope. Yeah.
Right. Last question.
There are unexplained causes of syncope. Won't it be a better idea as a message for the casualty officer that he should keep the patient for observation even though the patient recovers from syncope?
Yeah, for some time you should, but if
At
the
least
heart is
48 hours.
that will depend on the heart and the age. If the heart is structurally normal, if the patient gives old history of myocardial infarction, then certainly you should keep for observation.
Thank you.